All right. So today, what we're going to do, we have a bunch of cases that are actually real cases that we've had in the addiction clinic that we're going to kind of go through, and each of them has just a little bit different take on how or why or if we would do Suboxone. So they're just kind of fun. So we're going to run through some of those, and hopefully it'll be a bit of a discussion where, because there's not just one way to skin the cat, if you will. There's lots of different ways to do this. I'll be doing this with Alex, who works in my clinic. She's our nurse practitioner, who's pretty sharp with this stuff too. So we're going to have tons of fun. So next slide. So these are the things that are coming up. We have no echo a couple of times, both at Thanksgiving and at Christmas. So we have a couple other ones coming up, especially the one I'm looking forward to is the overdose surveillance data. Every year we try and do that to kind of see what kind of things are coming up in the state. So that should be fun. The one for Wednesday, December 10th is yet to be decided. So if you have a great talk, reach out to us. We're looking at some different things. Next slide. Remember, if you have any questions, please just reach out to us during the day. It's almost easier to probably use the phone and give one of us a ring. So feel free to give us a call if you have questions. Next slide. And again, all this stuff is online, so you can find a lot of resources at the CORE website. Feel free to check that out. Lots of different things, protocols, and all kinds of stuff. Next slide. The quick Zoom polls. We just get to do those all the time now. Dr. Wilcox showed up. This will be tons of fun, Mike. Which of these best describes you? Provider, nursing, pharmacist, behavioral health, or other? More providers than anything, 40%. Next. As a part of your role, I am working with MOUD. I don't work with MOD patients. I don't work with MOD patients, clients, and do not plan to in the future. And then not applicable. Perfect. Is that it, Katie? It is it. All right. So as we get going, please feel free to turn on your video. Always happy to see faces instead of black boxes. And again, as we start these cases, we're starting at ones that are more basic, doing buprenorphine and how we would do it in our clinic. That doesn't necessarily mean that Alex and I know the only way to do it. There's lots of times other ways to do it. But we'll kind of read the case and kind of present some questions, and we would love some feedback and things that people might have questions about or other ways people might think that they would do it. So with no further ado, let's go to case one. Oh, the agenda. Open discussion. Again, Alex wrote these. This is good because it says, do challenge anything that doesn't make sense. And again, we'll review cases from OP and ER settings as well, so outpatient and both in the emergency department. And again, most of these, or all of them, are from actual patients we've seen in the clinic. So next slide. All right, go ahead, Alex, if you want to read.
Sure. Okay. Case number one is the Narcan patient, a 29-year-old male construction worker who presents to ED on a gurney. He's alert, oriented, but irritable after receiving 3 doses of Narcan at the county fair. So Narcan given 3 times already. He's been using fentanyl for over a year, spends about $100 a day on his substance use, denies other substance use, does drink alcohol intermittently. Okay, so vitals, his pulse is 100, pupils are large, he's diaphoretic and crabby. While you're interviewing him, he jumps off the cart and runs to the bathroom where he has explosive diarrhea. He comes out and confirms he needs help and wants to be on medication for his opioid use disorder. It has been about 35 minutes since his 3rd Narcan. UA is not returned. What do you do next?
All right. Does anybody have any thoughts about how we might manage this patient if he is clearly, well, I guess the first question is, do people think he's in withdrawal? And you can chat this in as well. Is this person in reasonably good withdrawal? Anybody got thoughts? What do you think? How is this as far as withdrawal? Now, from my standpoint, when I'm seeing people in their withdrawal, again, I think that we all think about using, the cow scoring. And the cow scoring, as you all know, does have things in there that are more subjective than objective. When I think about somebody who's in withdrawal, I'm really looking for the things that I can prove. And so what things can I prove to show that he's in withdrawal? And those things would include his pulse, which is 100. He clearly has diarrhea. And honestly, that's one of the things that I love to see, because that just tells you that he's probably ready for buprenorphine. But he also has, he has these other things. He's very irritable, and you can see that. He's just a crabby guy who's tachycardic. He's sweaty. He's got all these things. And his pupils are large. So if he's in withdrawal, those are the things that you'd like to say. But he's in the emergency room and it's been Narcan. Now, some of you may not have dealt with patients who've been Narcaned before, so this will be a good experience for you. But does anybody kind of know what we do in this kind of case? What would our next step be? It actually got lots of options.
Or to help, I'll just throw out, if we're going to start a medicine for the withdrawal, what would we do and what dose would we expect?
High dose.
Yes. And how much do you think, Verna, that you do? Have you ever taken care of somebody who's been Narcaned?
No, not to start Suboxone.
Yep. And we do it pretty similar. So that's a good choice. You want to give them a reasonable dose when you start. One of the things when people have been Narcaned is that you would love to do it before that 30 to 40 minute mark. So if they come in and they've been Narcaned, it's really kind of what I would call as an addiction heart attack. It's time limited. You really want to get on them relatively quickly. Imagine as the Narcan wears off, suddenly the fentanyl's coming out of their fat and back into their system. They may not be quite as sick. So in general, he looks like a guy who's in withdrawal. He's going to need something. Next slide. So really, it's the sooner the better, right? And so when we talk about macro dosing, you can start with those doses that are right in that 16 milligram range, but you can bump it up and go higher before they leave the emergency department. We have quite a few of these come to our ED, and I'll tell you that it works really well to give them 16 to 24 milligrams. You just have to make sure that you continue it and that they get sent home with a prescription, because they will go back into withdrawal overnight if it's middle of the day when this happens. Now, the other option is, if you have availability of this in your ED, is Brixadi. And part of our protocols in our ED are to use Brixadi after a little bit of a test dose of buprenorphine in this similar situation. We've done that only a few times. There are a number of other places that are doing that, including Hennepin. There's some mixed results. And actually, one of the only issues with Brixadi is when people go home, there's about a 5% chance of precipitating withdrawal in the next 12 hours. So it's certainly something to think about. But yes, this would be one that you would give as in a timely fashion, a fairly large dose of buprenorphine. Any questions about that? Any other thoughts, Alex?
No, I like that you pointed out, I kind of think of it as like our triad, if you will, that I tell people all the time when I'm educating on opioid withdrawal that memorizing the COW scale isn't realistic. I mean, we don't do that. We kind of look at those big signs that they're in moderate withdrawal, which is the dilated pupils, goosebumps is big, tachycardia, diarrhea is like ultimate, absolutely hit them with high dose. So I just want to drive that home.
Yep, perfect. Any other questions? So yeah, so unless you have, now, can you do this in a clinic? I can tell you we have done it once in our clinic where somebody came in and been Narcaned at home and came in relatively quickly and actually received a big dose of buprenorphine in our clinic. So although this is an ED patient, it can be done even if for some crazy reason they come here instead of to your ED. All right, next slide.
All right. This is one of my cases. I shall be released. At the end, please let me know if you can think of the categories, that the ones in italics, all these titles are under a certain category. I did that for fun. This is a 46-year-old male who presents to your clinic requesting a restart of his Suboxone. He was first started on Suboxone 5 years ago after heavy daily fentanyl use and 2 unintentional overdoses. He stabilized on Suboxone 16 milligrams daily, but he ended up charged with a felony, had prison time for fentanyl possession and selling 2 years ago. So he had been on Suboxone, but then 2 years ago went to prison. While in prison, they tapered him off the Suboxone. So for pretty much that 2-year period, wasn't on it at all. But then he just discharged yesterday, made an appointment with addiction right away to restart his 16 milligram dose. Next slide. Okay, so right off the bat, do we have certain questions for the patient? Do you restart the Suboxone? And then if you do you resume that 16 milligram dose? You can also just throw this in the chat.
So yeah, what other information are you going to want from this patient before you start him on stuff?
Or in general, I like to think like, what are my key pressing questions I'm always going to ask before I ever restart buprenorphine, if that's helpful.
Any recent opioids, other opioids?
Absolutely. Yeah. We don't want to precipitate someone. And even if they come in and say, I got released an hour ago, it doesn't take much time to encounter something, right? So. Helpful for you? Is it something do you actually want to resume it? What's your goal with resuming it?
Has he taken any Suboxone since he got out of prison?
Good question.
That's very possible too. Sometimes they get out and they find they're able to get some from a friend. Yeah. So let's say he says, I haven't used anything. Let's say we get a UA and there's nothing in the urine. Do you restart at the 16 milligram dose? Any thoughts about that? Or does anyone have any protests to restarting Suboxone?
He hasn't had any opioids, neither Suboxone. I will go low, maximum 8 milligrams the first day.
Yeah, so we can go to the next slide and kind of talk through what we do here. Okay, so everyone did a great job touching on pretty much all of this. Always determine if there's been any return to use, possible fentanyl exposure since release. Like I said, even in a few hours, a patient could have went and used something. It's absolutely encouraged to resume the Suboxone. Now, I understand there might be a thought of, oh, he's been sober for 2 years while I don't consider that a true sobriety period because it was kind of a forced environment, really structured, and people tend to struggle the most once they're out of those settings. So if they're having urges like they're going to go use, absolutely, let's get them back on medicine for that, because this is a time that they're really at risk of overdose because now they're opiate naive. And then that was kind of the last point is, well, when we're thinking of how to restart the Suboxone, we have to think now this person's opiate naive. So while there's that greater risk of overdose, I might not hit them with the 16. Not that it's going to hurt anybody, but usually I might do like 4 milligrams twice a day, like send fours or do like an 8, say do half. If you're not sleeping, if it doesn't hit you, you could do up to 8, and I usually titrate them pretty quick. I know Kurt sometimes does that a little different than me. Next slide. I can't remember if I had one more thing to say here about that. Okay. And yeah, I just threw in, assuming there's no hepatic or reduced renal function, where, sometimes those people, if they're OP naive, we might really baby them in, like we might give them 2s or something. If someone comes in yellow, for example, we've had that. But I'm usually going to start, like I said, 4 to 6 milligrams a day at a time, give them room to go up to 8 the first day, probably get them to 16 pretty quickly. And sometimes these people, they really struggle just from the stress and being around certain people out of prison. So sometimes they get up to 24 pretty quick too. These are people I'm going to see like the next day or two and follow up, or I'm going to do like a phone call. Always give Narcan. Any questions about this case?
Yeah. And, from my standpoint, I'm always, really quick to get them up. And again, because we know in the studies that the faster a person's on a therapeutic dose, the more likely they are going to do well and not relapse. And so, although I would generally start around 8 milligrams as well the first day, by the third or fourth day, I'm up to 16. And then it might, I'm in no rush to get them up to 24, but I'm going to go there probably in this day and age because of the fentanyl, especially if they had a severe opioid use disorder with significant use in the past. So, and some of that is based on how they're feeling and cravings and dreams and all that. So yeah. Other questions?
I don't know if you found the chat in the chat, Kurt. It looks like there were questions. What happens if your patient no-shows for the follow-up appointments? And then what if they get sick from the 4 milligram dose? So with the no-show, that absolutely can happen in our world. I will say that, and I'm sure you do this too, Kurt, even though I'll tell them a certain dose, I always send extra. So if I'm sending 8s, I'm going to send extra 8s. So my hope is if I don't see them the next day, they have medicine. I'm always giving a cushion for that very real possibility. We continue to try having the nurses touch base or reach out just to make sure they're okay. If they get sick from the 4 milligram dose, are we talking like if they precipitated, or meaning like they didn't tolerate it? Just to clarify on that question.
Nausea and vomiting. Yeah, so if they get nausea and vomiting, most of the time, I think we all kind of do the same thing as I'll generally switch them to Subutex. The problem with that is it's going to take you 48 hours or at least a day to get the Subutex prior authorized, which is really a bog. Some of the state things right now are trying to get rid of that. And as a matter of fact, there's a push to get rid of all formulation and dose requirements for prior authorization, that it just will go through. But that would be my thought, is quickly switch them. Alex, what about you?
I would want to tease out what's causing the nausea, vomiting, make sure it's not a precipitation picture. I won't forget, we had a patient come in and we were lucky that we gave her a low dose because we found out after she had taken a boyfriend's methadone. Because she didn't do a UA, but that's never been known to this patient. Well, we would have gotten her sick. So, or if someone just, is using kratom, that doesn't show up in a UA. So if they're precipitating, if they're getting sick and it looks like a precipitation picture where there's other severe opioid withdrawal symptoms very suddenly, then I'm probably just going to hit them. I'm going to macrodose them the way we do to get them out of that. If it feels like an intolerance, maybe I could try 2s in the meantime. If it's like less of it is more helpful. Another thing that's faster than the PA for Subutex, you could try switching them to Suboxone tablets. In my experience, though, those tend to be crappier and less bioavailable. Patients don't like them, but that's something too.
They're like plastic.
Next slide. I think we're on to the next case.
The dental dilemma. A 30-year-old man shows up just having moved from a small town in northern Minnesota. He has been on 2 8-2 Suboxone strips for 2 years. He was just at the dentist and had 10 cavities. He wants to taper off the Suboxone to save his teeth. He was a very heavy IV fentanyl user for many years, but feels like it's ready to be off bupe. So again, he's only been on Suboxone for 2 years, thinking about stopping because of his teeth. Next slide. Before you agree to help him taper off, what information would you give this guy? What kind of things would you make sure he understands before you stop his med or help him stop his med? Any thoughts? And there is a thought. Is he doing good oral care? And that is a great thing. And, there were recommendations put out as to how you would take care of your teeth to avoid this. There's some thought that because of the pH of the strips, much like with methadone, that's part of the issue. Unfortunately, it sounds like that this actually softens the enamel in your teeth. And so you can't brush your teeth right away or you'll brush off your enamel. So the current recommendation, I think, is to wait 30 minutes and then brush your teeth after you take Suboxone, which, to be honest with you, in a rushed morning, I can imagine that would be a difficulty. But yeah, I mean, you got to kind of see what they're doing as far as their oral care. I don't know if you had other thoughts on that, Alex. Did you have any thoughts on that?
I was also going to bring up, sometimes it's actually been theorized it's dry mouth from the buprenorphine that is creating poor gum health, almost in the way like meth is constricting our vessels, and then we have poor oxygenation to the gums, and that's what leads to rotting. I always want to make sure I'm clarifying with patients what their understanding is of buprenorphine ruining their teeth, if it's something else, if that's the sole reason they want to stop the medicine.
Yeah. That's a good point with the dry mouth, because we do see occasionally people get dry mouth from the buprenorphine. I don't see it a ton, but people do complain about it. And just like anything that can cause a dry mouth, that can make your teeth worse. Now, the Sublocade is this a Sublocade candidate? This is definitely a Sublocade candidate. And they're actually a candidate in two different ways. Number one, let's say you really agreed with this patient that okay, you want to get off, it's your business, we'll let you be off. We can use Sublocade to taper them off, and a lot of you may have done that, where we give them a one-time injection, or sometimes I've done 2 or 3 injections over a few months, and then you just stop and it tapers them off without any withdrawal. Frankly, way easier than trying to taper their oral. But also a Sublocade candidate long-term. My first question would be to people, what's the risk of this guy relapsing after just being on buprenorphine for 2 years? Is it high or low?
I don't think it's high. Well, by 2 years, he should have gotten back some of his brain function.
Yeah, some of his brain is back online, but even in the day of heroin, the relapse rate, if you stop before 5 years, was almost 90%. And that was with heroin. So if we think about what's the relapse rate with fentanyl? I would be having a conversation with this guy that I really would hope that he would consider switching to Sublocade, because going off completely might be a high risk situation, especially because he was an IV drug user, right? Those people are probably people that buprenorphine is going to be a lifetime drug for. Thoughts, Alex?
I'll just echo that when we did this presentation for the boot camp, there was a study that said that it's not even about a year anymore. It's like 2 years. Within that 2 year period, there's still almost I think it was almost an 80% chance they return to use. I like to explain it to patients. I use the analogy sometimes of like cancer. You're in remission. We can stop the chemo, but it could come back. I don't know. Sometimes patients are more receptive to medical analogies, but.
There's a question, would you request them to be seen more often, like every 3 months or so? Generally, if this is a person who just showed up, I'm going to probably see them every month when they let's say he switched to Sublocade, and I'm going to probably see him for a few months every month just to kind of get used to him and kind of know his story and develop that relationship. Generally, once I get people out a year, then I will go to 2 or 3 months. usually 3 once they've been stable. And what if they stopped? Even if, what if he stops the medication? Yes, I also see those people back as well. I just had a guy recently who decided after 4 or 5 years he was going to stop. And we made an appointment for him to come back so that we could just see really how he was doing. And when he came back, it was like he was having using dreams. He was having all these things. And we had a conversation and he restarted his buprenorphine. So yeah, that's a fabulous thing to mention there. I think that if somebody does stop, you don't want to just not see them. I think it's great to follow them up. Oh, that was you, Alex, that put that in there. I didn't even notice that. But yeah,
for people that I give them that month prescription. Yeah.
Yep. Yeah, and that's perfect. Any other questions? Next slide. I can't remember if there's anything else. There's a couple of things here. Just remember, these are the things that I go off with, that I kind of run through. I think that we kind of hit most of these relapse rates, that what his options are, and also potentially discussing naltrexone. Okay. Now, I only have one patient right now for an opioid use disorder that's on naltrexone. Just recently had somebody switch. But I'll just tell you, we just, for the most part, don't do that here in the clinic. At any point this guy changes his mind, let's say he does say, I'm stopping, and that's just it. We will see him anytime, anywhere, call us, we'll restart it on the phone. So next slide. Any other questions with that one?
I do have a question. I just had to find my button for my microphone. Or not question, but you mentioned recommendations for dental care.
Yep.
Could I just Google that? I see every once in a while I have a patient that comes in that tells me that's why they stopped, was because they couldn't handle that it was rotting their teeth out. And I'd like to be able to give some education in case they're willing to restart and take different care of their teeth.
Yeah. And it's tough. And, of course, there's a class action lawsuit going on. A lot of my patients have brought that up. And so they're all involved in that to get money from the dental damage. And, it's certainly an issue. I don't think there's any doubt.
And I think if we could, and I work at an organization that has a treatment center too. So if part of what I can do and the other nursing staff here can be to educate on anything they can do to help prevent it, then I think that be good to know so that we could do that, at least feel like we're not misleading them or not giving them information that we have.
Yeah, and I think it's important to have that conversation right away. And so when I start people on BUP, I have that conversation with them immediately. You don't want to wait till a year down the road. I just had a woman who's been on BUP for, I bet 7-8 years, and she had been a prescription pill person and social worker, and she had 18 cavities the last visit, and so she admitted that she wasn't kind of following how they recommended that they do it. So she's really working hard at doing it a little bit better. Yeah, and Alex is correct. There hasn't been a perfectly established causation, but it seems to be a combination of things. So, do I believe it's the buprenorphine by itself? I don't. The other thing too, the last thing on the list, other thoughts, is sending that patient home with Narcan. Never forget, if somebody decides they're going to taper off, that everybody in the house knows there's Narcan in the house. And just understand too, I think that one of the worst and hardest things to taper off of is Suboxone orally. Again, much easier to do with the injectable. All right, next slide. All right. So do you want me to read this one? 18-year-old male presents to your clinic with his parents, tells you he's used about an hour ago. He wants to start buprenorphine as fast as possible. And his parents said it's been difficult to get the patient to come to our clinic. So they want to start him like right now. He clearly is just used. He is staying with his parents, and they're willing to bring him to the clinic as much as needed, which honestly, as we all know, transportation tends to be just this massive barrier when we're trying to start people. He's been using fentanyl for 6 months. He starts college in 8 weeks. Next slide. On exam, he's quiet and he's sleepy. He answers the questions. His pulse is normal. His blood pressure is normal. His pupils are tiny. Injection sites. He claims he's been smoking it. He's very polite, very motivated to get out of the life, as often patients say. He spent all his savings, sold his car to finance his use. And of course, his UA is positive for fentanyl and marijuana. How should we get this started? Because the parents clearly want something done today. And often when we get patients in the clinic, we want to do something. So I'm just wondering what people would do. What are you going to do to kind of start this man down his path to recovery here? He's going to be fairly close. He's going to be 25 minutes away.
If it were, I'm coming from a behavioral health perspective, but I would certainly consider like residential treatment that's going to support medication for opioid use disorder, because it will assist with the not having a vehicle, could assist with getting them stabilized, all those fun things in the beginning. That would be my preference or the way I'd go.
And we all would love to think that he'd do that, Mindy, but he says, I am not going to treatment. I'll take medicine, but I'm not going to treatment. I don't have time. I'm going to college.
Well, doggone it, Kurt, you just got to throw a monkey wrench in it.
Yeah, I know. He's not going. He's just not going to do it. So is there any particular way would anybody start buprenorphine on this young man today? Anybody want to do that?
Did you mention, Kurt, what time of day this was? Was this like in the morning?
Yep, this is in the morning.
Okay.
This is about 10 o'clock in the morning. Nice day. Anybody want to start bup on him today? And if so, how would you do it?
Do we need to educate parents on signs of when he's ready and have it, the prescription, the medication already picked up and in hand and ready? So do we feel like parents are able to make that assessment?
Yes, that's a yes. And Whitney says 2 milligram Phillips to go home with him, and then have him start every 1 to 2 hours when he starts to feel crappy. And that is definitely one of our options. Once we go to the next slide. So in my opinion, there's a lot of different ways to skin this cat. And even Alex and I think, would do it potentially different ways. But I think, I generally would give this person the strips. Now, could you actually give this young man Suboxone in your clinic? That's the first question. And the answer to that is yes. We do this all the time when we're switching people over from methadone or fentanyl or oxycodone. You can give them a quarter of a 2 milligram strip, and they will actually tolerate it. And then you can continue that during the day. I generally tell them to start taking it a little bit later in the day when they start to feel the withdrawal, if they have hanging around. So if you've got people hanging around the house and he's going to be around with his parents can keep an eye on him. I just don't want him to elope and go use. And so as long as there's somebody that says, hey, you're starting to feel sick, he gets a little loose stool, then he can start cutting those 2 milligram strips in half and just start taking that every couple of hours. And Alex is kind of popping some things into the chat. And I think that it's really important to know that in general, at that low a dose, you're not going to precipitate somebody. This is what I call going to be a Loma injection. This is a guy we're going to go low dose, probably overnight, where I'll have him taking this, half a strip, maybe every 2 to 3 hours overnight, and then bring him back in the morning. Okay. So I have him do that till then, and then I follow him up in the clinic and hope that they've gotten in 8 or 10 or so milligrams before we see him again. Yeah, and Alex, sometimes will go as long as 3 hours, just depending on, again, each patient's situation. Next slide. In the morning when I see these patients, let's say as parents, I say, listen, I want you to do this overnight. And I do, if there's multiple people there and I write this on their AVS, I'll say, listen, let's say it's 2 a.m. and you take a milligram and it doesn't take away your withdrawal. Take another half, right? You can start bumping it up a little bit. We all know that patients don't follow the instructions quite like we like them. But if you've got a family involved and you can say, here's what it says on the AVS, I circle it and say, late tonight, if something happens and it's not taking away your symptoms, double it. But when I see this patient in the morning, I'm going to give him 16 milligrams the minute he shows up. I might go as high as 24 or 32, depending on what we need to do to macrodose him in the morning. There's a lot of studies that show that when you give patients low-dose medications overnight or for a period of time, it actually expresses more receptors. It's kind of priming the pump, if you will. So kind of a nice way to kind of start that. Next slide. I can't remember whose this is, Alex.
This one is yours because all of mine are italicized in the title.
Well, yours are italicized?
Yes.
Okay. Do you want to go to one of yours because it is 12:50?
Sure. Yeah, we can go to
Let's go to the next one. There's one. Go ahead.
Okay, yeah. So this one titled "Baby Don't Hurt Me No More." Patient presents. So this is a really good ER case and a common thing we've run into. Patient presents to the ER on 24 milligrams of Suboxone. They've been stable on for the past year for past opioid use disorder. They suffered a shoulder fracture after a car hit their motorized scooter. There are otherwise no major injuries. They're in acute pain and asking for relief now. Their other medications include Abilify, gabapentin, and Prazosin. PMP only shows consistent Suboxone scripts as expected. Their last Suboxone dose was around noon, 2 hours prior. What do you do?
What is the age of the patient, Alex?
I want to say like 52.
Do you have the brand of the scooter or not so much?
I just know it was an e-scooter and it was a rainy day and she finally got a job and was so excited to go to work. It was really sad.
All right. So what are people going to do to kind of help her with her pain? And Whitney says initially, let's try a little Toradol or even some oxycodone if you have to. What do you think of that, Alex?
I would just ask, well, is that what you would do for someone not on Suboxone? Like, what would be the pain med you would expect to give for that situation? Take the Suboxone out of the equation.
If it's severe pain, you can give them, if the patient is okay with it, you can give opioids.
Yeah, absolutely. Next slide. I think I explained it pretty quickly on the next slide here. Yeah, treat them like anybody else with acute pain. Assuming, I'll tell you the caveat on this, but if you would typically give oxycodone, 5 milligram, maybe you do 10, whatever, or if you're going to send 5 tabs, 2 to 3 days worth, then do that. If you feel pain is acute enough and you would typically give 1 dose of fentanyl or Dilaudid, then do that. They may not respond as quickly. I know Kurt and I go back and forth on this. It's just been in my experience. I feel like they don't respond as quickly to lower potency hydrocodone initially. If you were to start with like a Percocet, then you could progress to like a Norco. That's been helpful for patients too. Patients typically on 24 milligrams of Suboxone still do respond to 5 milligrams of Oxy, assuming it's not like a severe acute injury where genuinely they just might need more pain medicine. But if they felt they needed a bump to 7.5 or 10s, that's been effective in the past too. Like patients I've had who had like total knees or whatever, and they're sent with 5 of Oxys and they're still in pain. They're taking their Suboxone. They've been stable from OUD standpoint. I just want them to be treated as a pain patient would be. The one caveat I'll say though is where this gets messy is if this patient hadn't been consistent with the Suboxone, because opioids on top of the bupe play nice just fine, not a problem. The problem comes in if we weren't consistent with the bupe, and if we throw a long-acting lipophilic med in there like fentanyl, because then I have to figure out how to clean up how I'm going to restart the bupe. If fentanyl's in the system, that's where I prefer things like Dilaudid. If it's ever unclear of when the patient last used bupe, I like nice short-acting, clean, non-lipophilic full mu agonist, because then it's a really easy turnaround for me to just restart the bupe. Just a thought I'll throw in there.
Yeah, I think one of the big keys, and she mentions at the bottom, is to keep it short. And I think that when I see patients like this, and we see so many patients with either injuries or surgery, I give them a pretty good idea of when we're going to be done with the opioid right from the start. I say, just so you know, this is something that's going to be 3 to 5 days, and then we're going to switch you over. So, don't let them be used to it.
Yeah. Next slide. Anyone else have anything? Questions, thoughts?
All right, next slide.
Oh, this would be basically just saying all the things I just said. So that's in written out form. You're welcome to look at later. Can move to.
All right, next slide.
Oh, this was just me asking what would you do if they hadn't been consistent with their Suboxone, which basically I would just avoid fentanyl at that point. I'd want to make sure that you could restart their Suboxone. That's an option certainly, but if they're already tolerant to it, it might not get on top of their acute pain. It just all depends on how long it's been since they've taken the medicine. You could give them a full mu agonist, but plan for it should be a nice, clean, short acting one so we can get the bupe back on board the following morning. It's as quick as sorry, go ahead, Kurt.
Yeah, I was just going to say, one of the things you mentioned, and this has happened to me multiple times, where they come in and they're in the ED, and the ED says they haven't taken their Suboxone for 3 days. Yeah. Okay. And that is where things do get slippery.
Yeah.
And you can still give them the opioid, but then I will drop back on their dose of buprenorphine, as Alex kind of alluded to. I might bring them back to 2 or 4, twice a day or once. I won't give them too much because I'm not going to want to precipitate them. They still have buprenorphine in their system, but you just don't want to go crazy. So be aware that you want to pull back a little if it's been a few days since they've used. If it's been 7 days, you pretend like it's not, the Suboxone's not even there, and you got to start really low while they're on an agonist, a full agonist.
Yeah.
Okay, next slide. 70. Now, I'm just wondering if anybody's going to pick up on what TV show this is about, who was in it. All in the Family. This is a 75-year-old woman. Her name is Edith. She presents to you. The names have been changed clearly in our cases to, keep people from knowing who these were. She complaining about nausea, vomiting, and sweating. She's been on oxycodone, 10 milligram pills, QID for 10 years. Her son tells you that the family has had concerns about her opioid use for some time. He called the pharmacy for a refill today and was told she could not fill for 8 more days. So she took them a little faster than she should have. She often seems confused and sleepy, and last month she crashed into the wall of their garage while parking. She has stopped coming to family events the last 5 years and rarely calls. She lives with her sisters on hydrocodone for chronic pain, but the son tells you that she rarely takes it, which is confusing to him because he just saw her pill bottle was sitting on the table and it was empty. Next slide. Next slide. So when interviewed, the patient notes that her pain in her low back has been worse than normal, so she had taken a few extra. Usually the doctor would refill a couple days early, but would not this time, as it was 8 days. She has not had any pills for 36 hours and just wants to feel better. She does have a couple of beers every so often and did yesterday, which helped for a while, and took a couple of gummies from a neighbor today that did not improve her at all. This is pretty common. When people are uncomfortable, all of a sudden they're calling their neighbors for every possible substance they might have. Next slide. When you go to see the patient, she's sweaty, she's irritable. She wants some pain pills from you right away. Her pulse is 105, her pupils are big, she's got a bump on her head from a fall. She's disheveled, doesn't look like she's bathed. Your nurse has gotten a urine test due to her back pain, sweating, and pulse, and it was concentrated in normal. You have your nurse do a urine drug screen. It's positive for oxyhydrocodone and cannabinoids. Next slide. So she's also taking her sister's medication. First question, does she have an opioid use disorder? Everybody's nodding yes. Yeah, she clearly has an opioid use disorder. She's missing family events. She's got tolerance. Of course, these are prescribed, but she's also taking unprescribed meds. So you could use tolerance and withdrawal as criteria, but she clearly has an opioid use disorder. What does your conversation sound like after the results of the urine drug screen? I mean, how are you going to kind of present this to this woman to make her not like go crazy? Anybody have a thought?
Kind of addressing it as concern about her quality of life and the lack, what she's capable of and how you can help her obtain that.
And I think that's a beautiful answer because I think quality of life is, and I go right there with these patients. I say, listen, number one, this clearly hasn't been going well. This isn't the way you want your life to be, I don't think. And I also make what happened to her, I normalize it because any one of us who'd been on opioids for 10 years is going to develop tolerance and overuse. And so I'm not going to blame them for that. I'm going to explain to them what happened to them is totally normal and that you're going to always try and keep away that withdrawal. And so taking your sister's was a pretty obvious, you got to do something to take this away. So yes, it's like, this isn't a good quality of life. I do think there's things that we can do better and ways that we can help her. So this is somebody that we clearly would start on buprenorphine, and she's been on, 40 to let's say 50 milligrams of oxycodone a day. How are we going to start her buprenorphine? Anybody have big thoughts about how we might start that?
When was the last time she took the oxycodone?
Oh, I can't remember looking back, but let's just say it's been, I think it was 36 hours. I believe it's 36 hours. So a day and a half.
So she should be in withdrawal.
Yeah. Yeah, Lance McNabb says, let's go to 16. And to be honest with you, you could probably give this woman whatever you wanted and she's not going to precipitate. Mm-hmm. Right? I mean, the oxycodone is long gone. And typically when I switch people over from oxycodone to buprenorphine, I just make them stop 12 hours earlier the day before. And I can give them the oxycodone. They're perfect. So yeah, this is a lady that's probably going to end up somewhere between 8 and 16. Yeah. And Alex agreeing that it's going to need at least 12. But remember, we're also going to be treating her pain. If in fact she has pain, we will see. Will she overuse the buprenorphine? Anybody think she's going to have a little trouble controlling that?
I'm just going to jump in here and share what all of my prison folk and men who love using drugs have told me. It's possible. We've seen people overuse bupe. It's rare. It happens. But I will tell you, bupe is just not that fun of a med to misuse. Someone, even if they do misuse it, if they're opiate naive and they take like 16 off the street from someone, they might do it once. It might be kind of exciting, and then it's not. It's pretty quickly kind of a boring medicine. It just doesn't shoot into the brain quick enough for the way that addictive medications do. And it dissociates slowly from the receptor. So it's not really causing that euphoria. Kurt can attest to this. How many times have we had patients say, well, I just can't feel it. I can't tell if it's working because I'm not feeling it. There's no buzz. There's no light feeling. And that kind of cues us into yeah, because it's working, but you don't feel high.
Yeah, that's really common. My experience with the chronic pain crew is when I switch them over to buprenorphine, even though buprenorphine does not develop tolerance in the same way that oxycodone does, patients, it's a ritual, it's habit to take things 3-4 times a day. And so often I'll have them cut the strips and take it more often so that they feel like they're doing something. Otherwise, they overtake it. It's often not that they need it, it's like they feel like they need it. Next slide. Why don't we go to the next one? We'll go to the next Alex one. And then we'll do the last one, Katie. Oh, there we go.
We should, so that one's not mine, but we should do the chocolate peanut butter one.
Oh, okay.
That's a good one. I'm stuck between that one or the foiled. Those are both really good ones. So up to
You've got chocolate in my peanut butter. So 27-year-old female presents to the clinic wanting help getting off methamphetamine. She notes that does anybody remember the commercial that this is referencing? Come on, Reese's peanut butter cups, where they fall into it and they get chocolate and they get peanut butter on their chocolate. Oh, come on. Well, anyway, she notes that she has to smoke meth every 3 to 4 hours or otherwise she becomes nauseated, gets diarrhea and sweating. When she uses again, the symptoms go away very quickly. And often she feels relaxed and takes a nap. She tells you it's never like this, quote, back in the day, unquote. She is not used for 8 hours, so I would see how she looks when she is sick. Next slide. On exam, she's a bit sweaty. Her pupils are mildly enlarged. She has a pulse of 105. She complains of nausea. Her skin is damp. She's fidgety. Her urine dip comes back positive for amp, meth, and fentanyl. Is this a false positive fentanyl? And what medication would you start first and how much? So does anybody think this is a falsely positive fentanyl? I see heads wagging no. And as we all know, there has been fentanyl in the meth lately. So there's some chocolate in the peanut butter. And that's just been a real problem lately that we just see continually. We have a lot of false positive fentanyls, but her story is more opioid withdrawal than it is methamphetamine withdrawal. So if you look at what her withdrawal looks like, it really doesn't look like the sleepy person. She's sleeping after she uses it, which should be more of an opioid thing. Would anybody start this woman on buprenorphine? What do you think? Anybody want to start buprenorphine on this nice lady?
Is she given history of opioid?
Well, we have a positive fentanyl, and she's got withdrawal, which looks like opioid. And Marcy Schmeezing says, for sure. And I did. I started her on buprenorphine. Now, how much fentanyl do we think she's using if it's in the meth? It's probably not as much as we would clearly see if somebody thought they were buying fentanyl. Mostly it's more fentanyl than anything else. So in my mind, it's always a little bit lower, but she's clearly sick. Next slide. And again, my first assumption is that she inadvertently became fentanyl dependent. So again, I don't think she's getting a large dose. I might start with 1 milligram or 2, maybe 4 milligrams twice a day. I'd start fairly low because I don't think she's getting a ton of fentanyl. But you could work that out over a few days, what took away her symptoms. Next slide. And again, you can do this a bunch of different ways, lots of different options. Again, we got to get a therapeutic dose as quickly as possible, and we're still going to have to at some point address her methamphetamine. But you could just give her 2 milligrams BID, and she's going to feel better. Again, it's just where are you going to land, and at what point are you going to have to bump her up? So, next slide.
Okay.
All right.
For the sake of time, Kurt, I want to make sure we can do your last case. So
Okay.
I'm just going to give my 2, because actually the one I was going to do is similar to the one you just said. So I'll just wrap it up and say this. I want everyone to remember that case with the fentanyl in the meth for another reason. The other case that I was going to do is called Down with the Sickness, is what it was titled. You can read it later if you want. But basically, be careful. It was a patient that went into the ED who was on naltrexone for drinking and had a history of meth and alcohol use. And that was it. And she just wanted to restart naltrexone, and they restarted it, and she precipitated because there was fentanyl in the meth. And so even that little bit of fentanyl was enough to precipitate her when given the naltrexone. So it's really important when you're getting ready to start BU. Even if the patient says, yep, I prepped, I didn't use any opiates for 12 hours, I always ask about meth. And if they're using meth, if they used it recently, then I'm checking UA for fentanyl, or I might be careful and do a lower dose because you can absolutely precipitate someone from fentanyl and meth. Anyway, we could, but yeah, we should move on to I want to make sure we have time.
Let's do the last case, Katie.
Yeah.
This was one that I just recently had in the last couple of days. And this is a case about, next slide, this is a case about our new friend 7-hydroxymetragenine. This one has been interesting. This was actually a patient sent to me by Whitney, and it's going really quite well. So this is a 46-year-old lady who shows up. She works in a nursing home, and she actually had a previous history of some meth use in her 20s, real heavy alcohol in their 30s, and transitioned to kratom around age 40, and has, I think, been using kratom roughly about 6 years or so. She transitioned recently at the behest of her friends at the smoke shop to 7-hydroxymetragenine. And the 7-hydroxymetragenine, she ramped up really pretty fast. To a level that I have yet to ever see. The highest I have seen since this, or prior to this, was 200 milligrams a day. And this guy was in withdrawal and literally pacing in my room. I was interviewing him while he was pacing. He was so ill. So she switched to that, and she had initially seen somebody in Litchfield, which was Whitney, and she was given some Suboxone ready to start on a weekend. She was supposed to started last weekend, but did not start it until this weekend. So we had her all set up to start to stop her 7-hydroxymetragenine and start a dose of Suboxone. Next slide. So every attempt that she's had to stop has been horrible. She's got severe withdrawal symptoms. They're unbearable. She showed up at our clinic very emotional, crying, not sure she wanted to stop. She had last used 2 hours ago. She was trying to actually not use on Sunday, coming in so she could come on Monday morning. But when she tried to do that, she only lasted just a couple of hours, and then she got panicky, felt like she needed to use something, and she literally took 500 milligrams of 7-hydroxymetragenine, which is an enormous dose. And the way that we had her starting was she was going to be taking a quarter of a strip of the bupe every 1 to 2 hours, much like I do all the time, after stopping cold turkey stopping. Which clearly she could not do. And interestingly, most of her ability to stop was behavioral. She had to have 7-hydroxymetragenine in her purse all the time, and she would think about it, and whenever she would think about it, she would take one. She had just spent the day before $200 on 7-hydroxymetragenine that she had in her purse when she came to see me. And just as an aside, she showed me the packages, and I took the packages and I set them on my desk, and I thought she was going to have a panic attack. She thought I was going to take them, okay, that I wasn't going to give them back. And I could see in her face that she was worried about that, so I moved them closer to her and said, I'm not keeping these. These are yours. Don't worry about it. Okay, next slide. So what happened, again, was she accelerated her dosing on Sunday and actually took 8 milligrams over about 8 hours, a quarter of a strip at a time. But again, she panicked midway through the day and thought, oh my God, I can't stop now. Took the 500 milligrams of 7-hydroxymetragedine all at one time. But all that Suboxone was in over a period of from about 3 a.m. until about 6 p.m. And she actually felt better than she'd felt in a long time and actually slept. She understand that she was taking 7-hydroxymetragedine every hour. And sometimes every 45 minutes. So in the morning, she woke up, she took her 7-hydroxymetragedine and came to our clinic having just taken 150 milligrams. And she was not sure she wanted to go through with this. And I actually had a pharmacy person shadowing me, and we spent an hour talking with her about what her options were. And she was about ready to walk out and not do this. And finally, I gave her some other options. I said, listen, maybe there's something we could give you here first just to help you calm down. I actually gave her some Ativan in the clinic. I let her go out and have a cigarette, which really helped. And then she agreed to take a milligram of buprenorphine in the clinic so I could prove to her that it was still safe to take. And she took that milligram in our clinic. Next slide. Now, part of the problem that developed here was that she was adamant she was not stopping the 7-hydroxymetragedine fast in any way, shape, and form. She was not going to do it. She had downloaded a 2-week taper from ChatGPT, which I didn't believe that they had tapers for 7-hydroxymetragedine on ChatGPT, but it was a very nice taper. And so she was thinking she'd do that and then come back and see me and then start the buprenorphine. So at this point, I had a few choices, and here's the choices I had. I could just give up and send her back to Whitney and say good luck. I could let her try and taper and bring her back in 2 weeks. I could just say, listen, we're stopping that 7-hydroxymetragedine right now, and we're just going to bring up your buprenorphine very quickly. Or we could slowly ramp up her buprenorphine and slowly taper down her 7-hydroxymetragedine, which I could not find anything in the literature suggesting that had ever been done with 7-hydroxymetragedine. It's something we do with methadone and oxycodone and all kinds of things, but I had not even heard of doing it with that. So these were my choices. Anyone want to think about what they might have done? Is Whitney raising her hand? She wants to pick number 4. Why would you pick number 4 there, Whitney? Because you're adventurous?
It's kind of a meet in the middle. Meet patients where they're at if she's not ready to let it go.
But we don't know if it's safe.
No, we don't know if it's safe. We could do it just like how fentanyl you would do fentanyl. Let her continue taking like the microdose.
Yeah. I mean, that's what I did. This is what I mean. What I did was number 4, but I'll have to say I was pretty sweaty thinking about it. Again, when we look at kratom, which has metragedine, which metabolizes to 7-hydroxymetragedine, there really has not ever been anybody that's talked about just leaving them on kratom and just slowly tapering up their Suboxone and then stopping it. Okay. And now we've got 7-hydroxymetragedine, which is clearly, I mean, it's like 3 or 4 times as strong as morphine, but it has a whole different mechanism. The question is, can we cross taper these patients like this, where we ramp up the Suboxone and we decrease her 7-hydroxymetragedine? And I just decided I had no choice, right? This is the only thing she was going to give me. Next slide. Unless somebody else sees an option. And okay, you can go to the next slide because we kind of already talked about this. So we can just open it back all the way up if you want to close that. So I'll just tell you a little bit about how interesting this was, because the highest dose I've seen of 7-hydroxymetragine was 200. And prior to that, I had a number of people around 100 milligrams, a lot at 60. But 1,000 seems to me really pretty epic. And so what happened the next day was we made an agreement that she would take a 0.5 milligram 8 times a day for a total of 8 milligrams for the second day. So I was going to try and go 8 milligrams 2 days in a row. And we were going to try and cap her 7-hydroxymetragine at 500 milligrams. And this is just all random, right? I'm making this stuff up as I go, right? I don't know if I suggest doing this at home, but this is what I did. We've been calling her from the clinic and from my house twice a day, trying to make sure that she's doing okay. She absolutely sounds fabulous on the phone. She has not felt this well in years. The first day she took 550 milligrams. Yesterday, she took 450 milligrams and we got her up to 8 again. Today, we are going to 12 and she's trying to cap it at 350 milligrams. And my goal is to have her off the 7-hydroxymetragine by the weekend because I don't want to have to call her on the weekend, but I will if I have to. But here's the interesting thing she said today, and I made it very clear to her. I said, you're feeling well because the Suboxone is on your receptors. You are not feeling well because you've still taken the 7-hydroxy. And she said, it's funny because when I take it, I don't feel it. Like Alex had talked about earlier, she couldn't feel it working. And so she's kind of figured it out this morning. She woke up and she took 100 milligrams and felt nothing. And 4 hours later, she took 50, and she said, I don't know if I'm going to take any more today because it's just not I don't feel it. But she's been cleaning her house. She's gotten all her bills taken care of. She's been working on a project at home. She said it's the most motivation she's had in 6 years. She's actually playing with her kids. And in fact, they were playing on the piano when I called the last time. So I guess the learning thing from this is that probably with 7-hydroxymetragine, you probably, if you get people that are taking it every hour, are not going to be able to just stop. I think we can consider slowly increasing their Suboxone carefully so that we do not precipitate them, and then stop and then just slowly bring down their 7-hydroxymetragine. But clearly, one of the most interesting cases I've seen. I just can't tell you how amazingly interesting this has been. So I don't know, thoughts, Alex?
I'm just going to throw out for anyone that we're very tentatively again saying this isn't evidence-based necessarily, but if you end up going this route and want to be as evidence-based as possible, you could try following the microinduction schedule. Now, Kirk got thrown into it. That's why he didn't start it that way. But technically, if you wanted to, you could try doing the 1 milligram, then 1 BID, then 2 BID. The way that we get people from methadone to bupe, you could certainly try to do that. But again, I would just document really extensively, just like I did in fellowship with patients who are going to continue using fentanyl. This isn't totally studied. There's a risk it goes wrong, but then you kind of document risk versus benefit of if they keep using. So I guess that'd be my one plug I would just put out there if people want to try that.
Yeah. And interestingly, I had a discussion with her and I told her, I said, I searched the literature. I can't find anybody that's ever done this. And I want you to know that. And so, you have to understand that I think it's safe. And I think we can do this and get you through and you'll be fine. But there is literally no literature. So I actually reached out to a toxicologist up in Duluth, said, have you ever even heard of this? And he had not. But it's clearly possible. But again, I'm not suggesting everybody does it at home. I don't know, Whitney, do you have other things? I mean, you met her and you kind of started this. I mean, other thoughts about her?
Yeah, I think, there's a lot of concurrent anxiety. And so that probably fueled all of it and fueled her delay for coming off of it. So, if her anxiety had been better managed, maybe we would have been able to get her to, withhold use and transition her quickly. But no, I think you need to write up a case report on this so that there is some literature out about it.
Yeah, it's been epic and it's not over yet. So again, but when you call and talk to her, she's like a different person. She's just really sounds great. So
that's awesome.
So that's the last case that we're going to fit in for the day. So we'll let everybody get going. We have a bunch of other cases we can do down the road. I hope these are helpful for people to kind of see how we sometimes do things depending on the situation. It could be different. So ending thoughts, Alex?
No, this is why I like this job.
Yeah. Okay. All right, everybody. We'll see you after Thanksgiving. And if there's anything comes up, please feel free to call. All right. Take care.